Good afternoon, everyone. Thank you so much for delaying your lunchtime to join us for this session, and also for your patience just as we allowed Amanda's live stream just to overrun that little bit. So we will try and finish on time so that you can get something to eat, I do promise. My name is Danny Mortimer. I'm the Chief Exec of NHS Employers. NHS Employers is part of the NHS Confederation. It's the Employers Association for the NHS in England. And for the best part of the last 20 years, we've been representing and supporting NHS organisations in England, and we lead some areas of national activity on behalf of the NHS and the Department of Health and Social Care. Our original plan, as you're probably aware, was for today's session to focus on the long-term workforce plan that you just heard Amanda talk about. And whilst that plan is imminent, it still hasn't been signed off and won't be published as yet. So what we want to do instead is reflect on some of the themes that we know the plan will need to respond to. And I'm really delighted that Joe Lenihan, who used to be the Director of Strategy at Health Education England and who led the Framework 15 work for Health Education England and the wider NHS, is able to give us some context setting around that. I'm also delighted then that we can reflect that theme of partnership and the fact that actually this isn't about the NHS operating by itself. In the fact that our colleague Honor Smith, who's the Chief Exec of Skills for Care, can join us to offer some reflections and responses from the perspective of her colleagues in social care. And that's really important because whilst we in the NHS are looking forward after the best part of 20 years to a workforce plan that's got some numbers in it, our colleagues in social care, we know, need equivalent attention and actually probably more attention given the particular challenges they face. And then the final thing is that we also know that in terms of delivering the workforce plan, that does need to speak to themes of partnership and innovation that we've talked about a lot this morning already. And I'm delighted that Raj Jain, who is the chair of the Cheshire and Merseyside Integrated Care Board, is able to join us to offer some reflections from the perspective of a system, and a system that has a particular interest in innovation and different ways of working, including with partners. The intention then is to get some input and some comments and reflections from you. We've got a little quiz just to bridge us into that, we'll have a chance for some questions from the audience, preferably out loud if that's okay. The app is available to pose questions too, but we'll come to you and you'll have a chance to ask the panel to reflect a little bit further as well. I hope that all makes sense. Joe, we're in your hands in terms of a bit of context setting.
Okay, great.
Thank you.
Thanks, Danny. Hello, everybody. Yes, so I'm here to talk about the work we did on Framework 15, which is the precursor to the long-term workforce plan, because as Amanda said, hopefully that'll be published shortly, but whether it's published shortly or not, the issues still remain. And actually, most of the levers to tackle the workforce issues are in this room or in our systems. And also, it's so urgent that actually my key plea would be sort of not to sit, I know you would never sit back anyway, but we can't just wait for these documents to be published. The issues are so urgent, we need to tackle them now. So I'll share some of the work that I did with Ona and others, taking a 15-year view, look at the future workforce. So it was based on Helen Whately, many ministers ago, asked us to take a 15-year view of the future workforce so that we could work back from that in terms of the actions we take now. Now, that may seem very indulgent given the urgency of the issues we face today, but I'd just remind you to think sort of 15 years ago, it was 2008, and we might all want to think about where we were in 2008, because I bet many of us were probably working in the system, and the decisions that we took then and the judgments that we made in good faith partly account for where we are today. So do you think it's a really good discipline to sort of to look forward to where we think we want to be in the future and make sure that the actions we take today take us closer towards that desired future rather than further away? That's the challenge we face as leaders. So I'll say a few things. A lot of our work was based on, we did a huge desk-based, evidence-based research, over 1,000 different documents, 1,000 different conversations, working with Skills for Care and other colleagues. We tried to make it really evidence-based because the issue, particularly when thinking about the future workforce, there are an awful lot of assumptions and opinions. And again, my plea to colleagues would be to, wherever possible, make decisions evidence-based. And everyone's always going to have different views about the impact of AI or technology but actually the issue is to be as explicit about our assumptions as possible. So when we do take decisions, we do it knowingly, and we're open, and we can keep those under review. So that's the work that we did. So the issues I want to pull out is to talk, obviously it's all about demand and supply, but in terms of demand, there are 3 different types of demand that I think we often get confused. There's funded demand, so that's the money the NHS gets given for something like, say, the long-term workforce plan. We've got a number of given outputs, and we then have to recruit the workforce to deliver that funded demand. Very important. Aspirational demand, I think that's what's set out really in a lot of the ICB 5-year plans, where we'd like to be over the next 5 years, the sort of strategies. Some of it which will be funded to 24, 25, and beyond that it's aspirational. But then thirdly, there's actual demand. That's what's actually going on in our population health, both current and forecast. And again, the trick is to keep a line of sight to all those 3, because even if we tackle one, we manage to deliver current funded activity, which is a hell of a challenge. Actual demand will not go away. We do have to be tackling that. So that's, I just want to be really clear about those 3. And again, making sure that our actions to deliver funded demand, the recovery of the agenda actually takes us forward towards what we know our population is going to need in the future, and not lock us into the past. That's particularly tricky. Turning on to supply, there are essentially, just put it crudely, 3 supply levers. You can attract staff by recruiting and retaining people who've already been trained. You can employ newly qualified supply, so education and training, new students, new clinicians, new doctors going on the training courses, and there's international recruitment. There's only really ever those 3, and what changes is the balance between them. So the work that we've done nationally shows that since 2014 we've doubled our reliance on international recruits. We're now twice the OECD average, and I've just been seconded to Birmingham Solihull ICB, where I'm applying our learning from the framework, and we've got a similar pattern there. Huge increase, particularly nursing and GPs. It's a national pattern, and Birmingham Solihull, they've increased their use of international nurses by 163%. So what we're trying to do in our work is say, do we mean to do this? Now, that may be a necessary contingent action we have to take in year, but does that align with our wider strategic system goals? So in Birmingham Solihull, as many ICBs are, we're really keen to create good local jobs for local people, to see that's an investment in social capital, in human capital, and indeed the economy. We know we've got a bulge in 18-year-olds about to happen across the country, which we won't see again to the end of the century. Now is the time to get new routes into work for our young people, which is a health intervention in itself. So if that's what we're trying to do, we might want to change that balance between international recruitment and domestically qualified. And then also, while we absolutely do need more investment in that newly qualified workforce that we get through education, training, investment, recruitment and retention is probably one of the most powerful supply levers we've got. The thing I've been saying to Birmingham Solihull recently is that you only get net growth if more people join than leave. It's really, really simple. But in some of the patches, and if any of you are involved, asking for trend data from former HE colleagues is a really powerful way of looking what's happened over the past 5 years. We do something called a waterfall flow analysis, looking at how many different people have come in from different routes, how many have left and gone on to different jobs. So you can break all that down really, really simply. We've got a HEF database that does that automatically of our key professions. And what we can see in some parts of the country is that over the past 5 years, thousands of staff have come into the system, but more people have left. So we're wasting a huge amount of money, but also probably damaging people in that process, not meeting their aspirations, their hopes of careers that they thought they were going to have. So tackling retention, which means fundamentally changing the workforce offer. Amanda spoke about some of those things. Retention is quite a simple word for a complex issue. But we know, for example, if we just return to the leaver rates for nursing, say that we had nationally in 1920 now, then by 2025, we'd have 7,000 more nurses. By 2037, we'd have 30,000 more. It has a real consequence, both on the numbers, but crucially on people's lives. Now, those things about demand and supply, they're not static. There are different drivers of demand and supply, and if we look at all the research, that be science, technology, population, demographics, people's expectations, both users and staff. So the work we did was sort of pull out two of those things. Population demographics, Amanda pulled out some of them. We know that by 2037, unless we do something different, in areas like Cornwall and Devon, a third of the population will be over 65, and 2/3 of those will have mental and physical, multiple complex physical and mental health problems. That will have a profound impact both on the demand, the nature of that demand. That will require not episodic care, but care that's able to be joined up with health and social care and other partners, chronic, ongoing, relationship-based care. It's not the way we're currently configured. And it will have a profound impact on supply, because if a third of your population over 65, who's going to care for them? How are we going to attract workers? Now, Birmingham Solihull Hall, the area I work in, is ageing less rapidly, a younger population, but they'll be competing with other parts of the country and indeed globally for our workforce. So it's really important we understand those sort of drivers. And linked to that, given that we are a people-based service, what is it that our people want? We did a lot of work with health and social care staff, because actually what our expectations of our staff is really important, and you'll know this better than me, but particularly the younger generation, they want more time to care, more flexible, adapted careers, but crucially they also want more time to live their lives. They simply aren't prepared to work in the same way that people of my generation would have been, quite rightly. My eldest is 22, and they have got a much healthier relationship to work and much stronger values. And unless we fundamentally change the offer of work, we're not going to be able to attract or keep the people that we need to deliver this care. And interestingly, that correlates with what patients, users and carers tell us they want from the service as well. They want a more holistic, preventative-based, relationship-based service, rather than this sort of, again, this episodic, transactional model we tend to have in the NHS. And it was a real privilege to work with Ona and colleagues with social care, because I think the ethos people described was much more common in social care, that asset-based, power-based approach to care that we're just not configured to deliver in the NHS. So we need to fundamentally change. I think about it as sort of a Venn diagram with 3 circles, in terms of people want a very different offer from the future care, a very different offer from the future of work, and that will require a very different offer from education, because we need to actually improve the literacy and empowerment capacity of our communities, but also of our clinicians. They're going to have to continually learn and adapt throughout their careers. In 1950, medical knowledge doubled every 50 years. Now it's doubling every 73 days. And that figure's from about a year ago. I'd imagine that's much greater even now. And we have to deliver all those 3. It's the intersection between the 3 we need to deliver, not trade off the one for the other. And crucially, in order to take that forward, the reason why it's complicated, because it's complicated, is that no one party holds all of the levers to do this. We need NHS, social care, private, voluntary. The levers to tackle the issues that we set out in the report are distributed. And that's why ICBs and ICSs are really so powerful. And I've been really energised and privileged again to work with Birmingham and Solihull on that. And as one of the reasons why I feel more hopeful than I probably would have done if I spoke to you 6 months ago. And I've just completed this workforce diagnostic for them building on this work. And we've got a framework for action now, just developing a delivery plan, which is also 4 R's, interestingly, slightly different R's to Amanda's. I was saying, first of all, we need to reconnect with our staff. So to build those, we clearly haven't got it right if so many people are leaving. That's some of those issues may be specific to certain organisations, but also the external factors around COVID, the strikes, the cost of living, generation expectations. We need a real conversation to reconnect with our staff. We need to recover net growth. This means being really listening to those, what people actually want from work in those conversations and addressing them in our retention strategies, not just thinking we know what people want. And then we need to reduce our reliance on contingent actions like bank and agency and international recruitment. Only do that if we get those first 2 right. So all these are very interconnected. And finally, we need to then of the growth that we keep, we need to redistribute and redesign that into primary and community care, because nationally and locally, most of our growth is locked into the acute sector. Both our current workforce and our future workforce, in terms of our trainees and students, are in the acute sector, and that's a stubborn issue. In 2001, 80% of nurses were based in the acute sector, 20% in the community. In 2021, it was 80% in the acute and 20% in the community. So we're trying to identify some trend-breaking actions in each of those headings in order to turn that around. But as I say, we don't hold all the levers. We're working really closely with social care partners and also the different organisations on the patch. What's heartened me, I've worked at HE for 10 years in workforce, and when I first took up the job, it was very much a minority sport. It was a niche topic. But now on the BC, all the chief executives see it as their urgent priority, and that it's everybody's business, and that if one fails, they all fail. And I think it's that sort of collective, we need to pool our collective sovereignty and our shared levers to really improve things both for our staff and for our patients and users and carers. So,
fantastic.
So there's a fast overview.
No, that's brilliant. Thank you, Jo. Yeah, I started my HR career 30 years ago, and I know of what you speak. Everybody's woken up to what you and I knew for a long time. Honor, we're in your hands.
Thank you. So it's really good to be back. I was just thinking about last year when it was just almost the go live date for ICSs, and I made the point that it's really important that social care is a source of answers and not just questions, and I still think that's really important, and I think it's happening more and more, and recognised more and more at a system level, and today in some of the stuff that Jo has said, that Danny said, and really importantly Victor as well when he started and kicked off the session. There's also much more of a social care presence at the expo today, which is great to see. So the social care stand, we've got the Tribe project, which is part of the UK Research and Innovation Healthy Ageing Challenge, and is a social care solution. So that's really good to see. The context in social care is in a lot of ways quite similar to the context that Jo set out for health. We have a high vacancy rate, so about 165,000 vacancies a day up until March last year. The new stats on that are due to come out soon. And we're going to need just under 500,000 new people working in social care by 2035 based on demographic changes alone. We've got some choices in that, but if nothing else changes. And so that gives a sense of the short-term issue and the longer-term trend as well. We also saw last year, for the first time in the time that we've been collecting the data that we collect, a 7% reduction in new starters. So we've always had high turnover rates, and as Jo said, that leaky bucket, we can keep bringing people in, but if they're leaving at a higher rate, that's concerning. But we also saw a reduction in people coming in and starting as well. So I think at that broad level, similar challenges. In terms of thinking about one workforce, I suppose I was reflecting on what Jo was saying and thinking we have to keep thinking beyond structures. So we have to keep thinking about relationships. We have to keep thinking about building trust, shared agendas, shared endeavours, shared values, and really respecting what we're each adding as partners, and not in a token way, but really a genuine curiosity. And I think that's one of the things I would reflect from the Framework 15 process. There was a genuine curiosity. Oh, that's helped us think slightly differently, and how do we understand your world and your perspective a little bit more, and I think thinking beyond structures helps that. We have to think beyond now. Now is really difficult, but the future is, we owe it to ourselves, our future selves, we owe it to future generations, we owe it to citizens to be thinking and have that future landscape, and to really think about the art of the possible in that. And I think with ICS as an integration, we have that potential. What we need in the future is going to be different than what we have today. It's about the shape of the workforce as much as it is about the size of the workforce. And so really challenging ourselves to think differently is really important. And that will mean having different voices in the room and different thinking in the room. And we have to think beyond organisations and organisational boundaries. One, workforce is about competencies and skills as much as it is about organisation and role. And to think beyond organisations, we have to make sure that we're engaging as much as possible across those boundaries. And we're already seeing that in a lot of the systems. We're seeing engagement with, from a Skills for Care perspective, our locality managers, our registered manager networks, nominated individual networks, CEO networks, really building that understanding across the system. There is no one blueprint for a one workforce plan. We all like a nice blueprint, but there are really common ingredients that should sit across. One of them is data and insights, and Joe spoke about that. And it's not enough just to have the data. I would say our adult social care workforce data set is incredibly helpful. It is at a system level. It's available for anybody to look at. But being able to look at that and draw the insights from it needs input from people who really understand social care, what's going on, why is that happening? And to do that, we need to consistently engage adult social care leaders. But it's not just engagement. We, from a social care perspective, need to empower and enable adult social care leaders to really play a meaningful role in one workforce plans. And we need to embrace that role and embrace that insight. I always make the point, and Joe just talked about the different levers that we have in health and social care. We have very similar drivers when we're thinking about the future. So demographic changes, technology, different expectations from citizens, but we have different levers. And I would say that understanding those levers is incredibly important. But I would also add that as we're going through our integration journey, the more that we can do to bridge the gaps between health and social care, and that doesn't mean to try to make everything the same, because actually we need to respect the difference, and we need to really value and recognise that difference. But thinking about how we bridge gaps in language, how we bridge gaps in starting points, so a clinical starting point as opposed to a social starting point, they can be quite different. So how do we bridge that gap? How do we share that understanding? Gaps in terms of esteem, parity of esteem that we hear and talk about quite a lot. Bridging gaps in terms of funding, terms and conditions. What we do in one part of the system has an impact in other parts of the system where terms and conditions are different. And back to the NHS long-term plan, there will be a gap when we have a long-term plan for the NHS and we don't have the same for social care. So how do we bridge that gap and build that understanding? So I think I would say there's great stuff already happening, and we've got loads of examples of adult social care being deeply involved in workforce planning. We need to keep that momentum up. We need to keep trying things. We need to keep the engagement up. Really value each other as partners. Value what social care can bring to the conversation, and value our difference, but keep trying to bridge the gaps between the systems.
Fantastic. Thank you so much, Honor. Raj.
Thanks, Danny. Firstly, just to reinforce my support for Joe and Una's points that they've made, it very much resonates with the thoughts and issues that we face across in Cheshire and Merseyside. I was once a HR director many years ago. It was 15 years ago.
All the best people.
They are. And it does feel as though that was in the early 2000s. It feels as though we're at a similar sort of point, but with some differences. I can sense a lot of opportunity. I can sense that people are excited about what we could do. The difference, of course, is the money, and what we were able to do with the money then.
That's interesting.
I've got really two thoughts that I wanted to convey today. One is starting with the issue about retention. As Joe says, if we cannot fix retention, we're sunk. It doesn't matter how good we are at recruitment. And people will know that there's an NHS approach to occupational health. Really important that we do get that out into all our organisations, because our occupational health services, with notable exceptions, are not where they need to be and pale into insignificant to other large organisations. So we don't care well for our staff. And if you look at the staff survey, one of the other issues that comes out strongly is that our staff want more from senior management and leadership. I think when you delve deep into that, what does that really mean? That they feel disempowered. They feel as though they don't have the accountability or authority that they used to have, or perhaps would want to have again into the future. So if I was doing one thing and one thing alone about, as we await the national workforce plan, it would be doubling down on how do we support our staff to have those rewarding and meaningful jobs and careers that they want. So I guess everybody recognises that in the room. That's not a massive insight, is it? Where I wanted to go to was the one workforce issue. And I was chair of an ICB. I'm the vice chair of the ICP in Cheshire Merseyside. And it's far easier for me to see the benefits of one workforce from my new role compared to when I was a chief exec of an NHS organisation. But the good stuff is you see we've got 18 providers in our patch. You can see that chief execs and the boards of those providers recognising the opportunities that a one workforce brings, recognising why working in place is a good thing. More work to do on that, but you absolutely do see that. And why is it important? We've just heard from Una what some of the issues are. I'm going to translate that into some of the imperatives that we're facing. There's an NHS set of organisations in our patch. And the imperative I want to talk about is productivity. Now, I don't like the word productivity. It's never really resonated well with care staff. But if we talk about frustrations, waste, how do we do things better, how do we make my job better, those are the phrases that resonate far better with care staff than productivity. And we have a range of approaches to that, don't we? However, what we don't do is leverage the data sets that exist across the system. So, social care, voluntary sector, the police, education. How do you bring those data sets together to give us greater insights about where we should focus our attention to achieve the objectives that we're trying to attain for population health, reducing health inequalities, reducing the demand in the NHS service? In Cheshire and Merseyside, we've been able to bring some data sets together and develop some insights. Happy to talk about that at a later time. And so it's effectively a risk segmentation tool. That's what it is. I've seen lots of these tools over the years in the UK and internationally. I'm going to be biased, aren't I? But the tool that the people in Cheshire Merseyside have developed is one of the best I've seen. Because our care staff say it's useful to them and it's cheap to deploy. It doesn't take billions of pounds to bring it to light. But what it's doing is helping us understand what those key interventions could be in upstream that enable us to support citizens far better, communities far better than we are now. This is not conjecture, this is not just a vision of the future. We've got this stuff working now in pilot form in Cheshire Merseyside. So we categorise people into the usual frail and elderly, complex lives. Let me talk a bit about complex lives. The stats around complex lives are truly outstanding. The level of usage of care, whether it's social care or health, NHS care, is multiples of normal people. From an NHS perspective, we've estimated that those 11,000 people in Cheshire Merseyside who have complex lives, it costs about £315 million a year to care for those individuals. That's just NHS. Let's add a lot more on for social care. But we can see with that data how we could make interventions early on in the person's journey towards ill health and social issues. But we are faced with this, which is these complex patients are generally known to the services, whether that's social care, health, police. We can put up example after example where individuals and their families will have multiple visits are totally uncoordinated from public authorities. One example I saw was a lady, substance abuse, 2 children. She had 14 visits in 1 week. And the lack of integration is significant. The opportunities to do so much better for that family are really significant. With the way that the data is presented to care teams, we are seeing how those agencies, those different organisations across the care system can work very, very differently. And they're doing their best now to work differently. We're taking down some of the hurdles that prevents that. It's far easier to do at a local level than it is to do at a higher level. You have different conversations, different things. But what we can also see is that it's evolving and giving us insights on the new type of workforce that needs to be developed. There are some early wins for us. Do we think we're going to make a difference with this data set for this winter coming forward? We absolutely do. It's not going to cure our ED issues, but it will make a difference. Can we move people from their silo working into working more collaboratively together to do different things to support those families? Yes, we can see it. We're not designing those, the care teams themselves are doing that. That's great, good stuff. But there does need to be a strategic approach to it. We do eventually need good governance frameworks between us. But what underpins that is our partnership working. It will both be powered by or completely denuded by the sets of relationships that we have in each of our places, the sets of relationships that we have at Cheshire Merseyside. So looking forward, I am optimistic. I can see in the short term some wins that will enable us to support better care and manage some of the productivity conundrum that we have at this moment in time. But I am a bit anxious about the future, about the silos that are coming, an NHS workforce plan and a lack of a social workforce plan, and because those two need to be, to help the teams on the ground, they need to be connected so that we can develop new roles for the future.
Yeah, fantastic. Thank you so much, Rose. And I guess one of the interesting questions for the future is how we can have that kind of sense of convergence between health and social care in a way that recognises what Honor said, the things that are the same and the things that are different. I think in the interests of time, I'm going to make an editorial decision to skip the quiz. It's on the app. But what I'm going to invite you to do in the audience, if this is okay, is turn to your neighbour. I know. Turn to your neighbour, make a new friend, or...
So you're the HR director?
Yeah. You know, I've done this really bit. Turn to your neighbour and just for 2 minutes, just reflect on what you've heard the panel say and identify one thing that you'd like the panel to talk about a little bit more, or that they've talked about, or maybe something they haven't touched on that you'd like them to pick up on. So the 2 minutes starts now, and we'll do the kind of mics and put your hands up and all that kind of stuff in 2 minutes. Don't run away. Don't be... Just literally just talking to the person next to you. It's okay, I promise. Thank you.
I hate when people do that.
Well, mix it up a bit. Fantastic, thank you.
Good stuff on that.
Good work.
Get some water.
What time is it?
It's 5 to 1.
Do you need more water? Is it really? Oh, wow. What time did we start at?
We started at 20.
I really like what you said.
Oh, how long did I talk for to start?
It's okay. Don't. Okay, colleagues, we'll start again. You'll notice just on the screen that as I suggested you talk to the person next to me, Joe said, "I hate it when people do that," and our transcriber faithfully typed it up, and I said, "It's good to mix it up, get some water," and the transcriber faithfully typed that up too. So there are no secrets. There are no secrets at all. If we could we raise the lights slightly so I could just see? Oh no, I can stick my hand to my eyes and see you a bit more clearly. Oh hello, there's more of you than I realised. Is there anyone who'd like to kick us off first in terms of a thought or reflection? Hello, could you say who you are and where you're from so we can track you down later?
Hi, my name's Jade Winnett. I'm from Surrey Heartlands ICB.
It's very nice to meet you.
I'm a programme manager. Currently looking at the temporary staffing financial recovery plan part of the issue.
Nice easy job you've got there. Okay.
Brilliant. Do I have to do a summary? I wasn't doing a summary, I was doing...
No. It's to ask, to make a point that you'd like the panel to kind of expand on further.
So I think the biggest thing that I'm finding in working with trusts on this kind of issue is the trusts in Surrey are working very, very hard to look at their spend, their temporary staffing, how they can look at pathways differently, all the controls they're putting in place, rate cards, that kind of thing with the industrial. They're working, temporary staffing teams are working really hard to do this. When we look at specific programs like maternity, we've got a massive issue that we're finding out about mental health workforce within acute trusts at the moment. When we're looking at those issues, when we lose the support from the trust and the founders, the fact that when they save lots of money, we can't give it back. We can't say, okay, because it's part of financial recovery plans and things. And a lot of the solutions that we're looking for, it is about pre-investment. It does offset the savings that would be made. But I guess when you ask for what we'd want, it's, how can we bid for... We're getting lots of support from NHS England with the kind of work itself, but are there any ways we can bid for those kind of front-runner programmes?
So this trade-off between investment and the kind of return on investment we might get through the kind of programmes that you're leading. Really, let me just see if Raj and Joe have got any reflections on that to start us off with. I've got a question that someone's put on Slido as well, which I'll pick up, and then I'll come back out to you. So Raj, from that trade-off in terms of investment and kind of the return on investment, you touched on it a little bit.
I might have misunderstood.
Go on.
In terms of those sort of programmes and schemes supporting the delivery of SIPs for the organisation, that's a big win.
Yeah.
And people should be congratulated for it, and it's really important because it does release cash that's going to be tied up in that otherwise, and to good benefit. But in terms of investment and rate of return, scale is really important on this one. There are some trusts, I think, that are big enough in their own right to be able to take this forward, but not a lot. And even those large trusts need to work together. And I think if you work at the appropriate scale, you've got bankable investment cases that could attract the right investment nationally, but also looking at your ICB and the way it's approaching some of its investments, you're more likely to gain the investment that you need.
Fantastic.
If you're from Cheshire Merseyside, that's not a yes to any scheme.
But that's a classic example of where our short-term actions delivered in your demand delivery plans can contradict where we're trying to get to in the medium and long term. So I think that's a great example. And so what we're looking at in Birmingham is actually how can we, if we save money on bank and agency, can we take a slice of that to reinvest then in the actions that if we do the reconnect exercise with our staff, and then we can actually start to fund things that will help help them to stay and progress in their careers. That absolutely makes sense. And I think, yes, I think doing it scale as a system, but I think also NHS England want us to deliver this as well. So I think the long-term plan, when it's published, a long-term workforce plan, there'll be a delivery plan, obviously, to follow up from that. And then that's our chance to feed back to people, actually, let's get the incentives aligned. Part of the delivery plan has to be aligned incentives. And because ICBs are working closely with Amanda and her team, you've got 42 people have conversations now, we can feed that back and say we need to get our ducks in a row on this.
And I would add, I mean, particularly around the kind of bank and agency, the kind of premium costs. I know Navina and I gave evidence together to the Health and Social Care Select Committee when the now Chancellor was the chair of the committee, and he was particularly interested in that kind of agency point as a compelling kind of argument for the plan. I appreciate he balances different compelling arguments now that he's Chancellor, but it was something that we spent quite a long time talking to him about at that point. So that specifically, it's important locally, but it's also important nationally in terms of making the case for the plan and the investment we need from the government in the plan. A question's been raised on Slido, and then I'll come back out to the audience if that's okay. And just to come to you first, perhaps, Honor, about this, Joe rightly highlighted that in the healthcare sector and social care sector, we are very reliant on international recruitment. And clearly there are questions rightly being asked about the ethics of that and how we balance the kind of benefits to our population against the impact on populations, particularly in the developing world. I know recently there's been a lot of attention placed on particularly the continent of Africa and recruitment from there. From the perspective of your members in social care, that kind of balancing those ethical dilemmas, have you got any reflections on that? And then Joe, perhaps come to you again.
Yeah, so we saw last February care workers added to the shortage occupation list for the first time, and we've seen a significant increase in international recruitment since, so about 60,000 people. That has really helped with capacity, is what we're hearing from employers, that they really have relied and welcomed people coming internationally. We're doing a lot of work around how we support that to be ethical, to support people to settle into the local communities, to support providers to make sure that they have well-being at the heart of that. I think there's definitely more to do. That's a lot of people in a short period. And so I think our focus on ethical recruitment, both in terms of where people are coming from, but also when they're here, how are they being supported, how are they being supported within the workforce, how are they being supported to settle in. And I think that needs to be to stay on our radar. The future of that in terms of international recruitment is hard to know, but I think we need to keep that conversation going.
And I guess, Joe, that's part of the motivation for the plan as well, is to reduce some of that reliance.
Yeah, reduce the lines, but also to have an explicit conversation about it. Because let's be clear, same with banking agency, what is the root cause? What is driving? These are contingent reactive actions we're taking to problems with the work offer, that we're unable to attract or keep people to jobs, which means we're having to get a banking agency because the nature, the way we employ people for 12-hour shifts, we need to get to the root causes, and then actually, if we do, we won't entirely switch it off, we have to do it more ethically. There are choices. NHS Global do a lot of work about making it a positive thing, seeing this from a global perspective about earning and sharing, so that more of our staff go abroad and learn and share and bring that learning back, and vice versa. There are potentially positive ways of doing this, but this very short term, just sort of plugging our gaps in a reactive way without tackling the underlying fundamental cause, I think, is what we need to tackle.
Fantastic, thank you so much. Let me throw it back out to the floor again, see if there's any more questions. We've got two colleagues here at the front. Go for the lady in the second row.
Thanks very much, Danny.
Who are you and where are you from?
Janet Wilkinson, Chief People Officer for NHS GM Integrated Care.
Thanks, Janet.
Obviously, I've always been really passionate about One Workforce, and I know some of you are aware of that, and recognising the progress that has been made in terms of the fact that social care colleagues are more involved, we are talking much more about it. I'd be interested in hearing the panel members' views about what we can do collectively to influence national policy to actually make a real difference and achieve those ambitions.
Specifically for social care?
One Workforce.
One Workforce.
How do we treat them both the same?
Okay.
Thanks.
Honor, perhaps to start with you and then come to Raj and then to Joe.
If I had to choose one thing, I would say we can't underestimate the unique and powerful voice that our health colleagues have when we're talking about the value of social care. health colleagues really understanding and talking about social care being part of the solution, part of the system change, and a fundamental and equal part has a massive impact. So I would say keep focusing on the real strengths of social care and what we can bring as well as what we can learn, and I think that would be really valuable.
Thank you. Rob?
If I just add to that, I think colleagues in the NHS working at system level can leverage and support some of the political relationships that we have at an ICB or an ICS system. So where we're able to demonstrate the real good that can happen through one working, where we can talk the investment case really well, where we can talk about it in terms of the imperatives that both government and other national bodies are focusing in on, and that's done with a joint voice across the system at an ICB level. I think that's really useful and powerful.
Joe?
I guess I think we just need to remind, I think what I'd like to try and do, is I've worked in NHS for 30 years now, is to remind people that it was never always this. So we don't have one workforce because the way that we employ people and the boundaries we put around different organisations, those are choices people have made at different points in history, and not to say that they don't always have to be that way. So prior to the 1990s, when trusts were invented as competing organisations, clinical staff were employed by regional health authorities. They were a system-wide resource. So just worth thinking through sort of why are we sort of working against the boundaries that we're in, having to rely on goodwill. There are choices to be made going forward, and ICBs are a perfect opportunity to allow maybe some piloting, some experimenting, actually, that if we actually were prepared to be more radical and think about employment and other barriers, sort of issues that get in the way of that, what could we achieve and how much could we save? I mean, I think the money would be a really key driver of interest for this, as well as the health and well-being benefits.
And I'd reinforce the point that Anna made earlier, which is this is fundamentally about relationships. And I do think there's something about understanding, helping politicians, and we've got the Shadow Secretary of State later today, and we've got the Secretary of State tomorrow. There's something about helping them and their teams understand that this is about allowing you in Manchester, Raj in Cheshire and Merseyside, to develop the kind of relationships that Anna referred to, Raj kind of touched on, in terms of how actually we can kind of forge new ways of working, new models of care through those relationships. And that's most effectively done in Greater Manchester, in Cheshire and Merseyside, than in Waterloo or on Victoria Place or on Victoria Road in London. And there's something about that, and that does take a bit of time. It does take a bit of patience in terms of trying those things, and sometimes it involves trying things that you need to kind of rework and try again. Thank you, Janet. That was fantastic. And there's a colleague just in front of you. You've been very patient. Thank you.
Thanks so much. I'm Beth Sutherland. I'm a nursing workforce policy manager at NHS England.
Hello.
And it's really great to hear about how we need to change the shape and the size of the workforce in the future, but also the ways of working really need to fundamentally change. And I'd just like to hear from you all about, in terms of multidisciplinary team working, there's so much potential there, but actually implementing that in systems on the front line has the risk of creating quite significant professional identity challenges as well. And how do we enable colleagues from different professions to change the way they're working that's been different for the past decades that they've been in those professions? How do we enable them to do that and work collaboratively?
Fantastic, thank you so much. I suppose the one observation I'd have before I kind of just bring colleagues in is, of course, that we see, in certain services and certain specialties, we see that ethos already pretty strongly. I'm always struck by it in mental health in particular, particularly my background's in acute services. I'm very struck by the contact I've had with mental health colleagues. I think we do see it more and more in some community services. We see it in some of the relationships that Anna referred to. But Joe, from your point of view,
Yes.
I know this was a feature in the
Yeah, no, it wasn't. Thank you. I didn't get a chance to say that earlier, but absolutely, this is all about it's more and different, and working differently. And it's not just the whole sort of roles versus skills thing is a massive issue. So, you know, this sounds crude, and I don't mean it to be, but a professional role is almost like a proxy for a basket of skills that we think we might be needed to deliver particular sort of activities or care. And all the young students and trainees we spoke to, they want to work in multidisciplinary teams. They want to have flexible, to be growing different skills throughout their careers. They're not as rigid in their thinking about particular professions or roles and boundaries as we have historically. And we need to find a way And I think partly it's because we commission roles, we plan for roles because that's our currency. And it's actually really hard to be granular and say, so for neighbourhood teams, I keep saying in BSOL, so what activity do you think is going to be carried out in a neighbourhood team? Is it respiratory care? Is it foot care? Mobility assessments? You need to define what the activity is, and then we can say, actually, okay, what skills are needed? Because maybe we already have that, and somebody just needs another 6 weeks to top them up. We can train people in, rather than it saying, actually, oh, that's a nurse or a particular, which is actually very expensive, very rigid, mixes off the gaps. And we did it during COVID. That's why I think we some parts of the country were so successful, because we started with what we had. We knew we had a shortage of anaesthetists. Then we looked at, well, who's actually had experience of airways pathway management? That was the skills that we needed. And what other skills, or you know, to vaccination? How can we train people? So be much more granular about the skills that we need to deliver this care that's required, which is some of the work that you've been doing, Raj. That sort of very granular data to get a better understanding of that, and recognising that our students and trainees, they want to work with health and social, they want to learn and train, so learn in multidisciplinary ways and then work in multidisciplinary ways, because that's what users and patients need.
Raj, that probably segues into you next, and I'll come on to Honor. I mean, I guess that lay behind slightly your example as well, in terms of the person with complex needs who had 14 different professionals kind of in touch with them in a single week.
But I'll give an example from the acute sector, because I think it's relevant to the question. And I'm hinting at how the acute sector can change. So I saw in another country, in the US, a phenomenally different approach to MDTs around cancer care. So this is pre-diagnosis all the way to care and rehabilitation into the home, where they were using data sets, AI, to bring together a wide range of different professions, a wide range of different carers who were making remarkable differences to people's outcomes. The key thing was the data and the way that was visualised across that care community. And we're yet to fully understand, I think, the opportunities that are going to be presented to us. That will be orders of difference that data and AI is going to bring to how we will need to develop our workforce, and also the opportunities it provides to connection across communities.
That's a great example. Thank you. Yeah. Honor, from your point of view?
I was just going to say it's an absolutely brilliant question. I think if we were to anchor the workforce around the need and what matters to individuals, I think that completely flips the perspective, and it leads us, if we have that as a principle level, then it leads us in all different contexts to think differently. If this is about the individual, how would I plan this differently? How would I think about proximity to people's doors and not proximity to hospitals? How would I think about skills and competencies, not roles and organisations? So I think there's something about the starting point in it. And I was really struck this morning by something that Victor said, which is that the future is decided by the things that we don't talk about and the conversations that we don't have. So let's have those conversations, because I think that's really important. And bit by bit we'll move, and bit by bit we'll bridge those gaps. But having that shared principle of let's think about the individual at the heart, I think will be helpful in any of those contexts.
And there is something about the enablers for that, because I guess sometimes we sort of say, well, look, it's not happening, it should be happening, and we talk about the kind of professions, and we almost make it their fault. Whereas actually the example you gave, Raj, it's about how do you use technology and analysis to enable that different way of working. For those of you that are going to visit the exhibition on the UK RI stand, there's a fantastic example from an organisation called Tribe, a not-for-profit that's working in 5 ICBs now in England, about how they're using data and AI to drive some of that those different ways of working. So there are some things about how we enable this as well, which are really important. One final question, just at the back of the room. Hello? Hi. Yeah, no, I can. Hello, sir.
Yep. Can you hear me?
We can, loud and clear.
David Warren, Chair of Nursing and Midwifery Council. Linked
Hello,
question with my neighbour Billy, who is a non-executive director of a university. Billy's question is, can the panel better define productivity? Mine is, how would that work with what seems to be coming out of the talk about the workforce plan of lower academic qualifications.
It's a nice, easy one, David. Thank you. To finish this up with, well, Raj, you've obviously had some thinking about productivity. You touched on it. Maybe ask you to pick up the productivity point, and then the lower academic qualifications thing, Joe, maybe I could look to you, and then we'll have a quick upsum, and I'll let you find some lunch. Raj, productivity.
Okay, so I think a lot of people in the room will know about the model hospital and definitions of productivity and their weighted unit averages and that type of stuff. I think they're important measures, those benchmarks. The GIRF review gives us another lens on productivity in the acute sector. It's far more of a desert in community services and primary care, but we do need to get better at measuring impact against the outcomes that we're seeking. And that's where I would diverge from some of the base measures that we're currently using. I think they're really important to have those hard measures in theatre productivity, for example. However, when we look at a population level, how do we define productivity in those things? It must be that we segment it. What makes a care worker's life a lot easier to support better outcomes for the citizen? What does the citizen regard as being productive and effective care? And we need to get better at measuring those beyond the satisfaction surveys that we that we currently produce. I better stop because I'll talk all day.
No, but that point about impact, about more sophisticated definitions is really important. Joe, that point about qualifications?
Qualifications, yes. So I know it's a heated debate, and my personal view is it must be right to try and find new routes into meaningful careers in care for people. But I would point you to the title to this conversation was one workforce reframing our thinking. And when people say should we have degrees or not, my personal view is that's a 20th century way of thinking. This isn't about how quick, whether you do a 3-year course or a 2-year course. Our staff are going to have to continually learn and educate. The question is, how do you enable everybody who joins us to have access to lifelong skills and learning, which they will need in order to keep up to date with the pace of technological, scientific developments, changing people's needs, bespoke things, and to keep themselves interested in progressing in their careers. So I increasingly think it's a bit of a distraction, which I know everyone loves to talk about, but we're missing the real issue here, is that we need to fundamentally revolutionise the way that we educate and continue to educate our health and care staff to deliver the care of the future.
And in my upsum, I'll use that. I've got 2 minutes and then an alarm sounds, I think. I'll use that as the first point. There are clearly important conversations to have as we implement the plan about how we bring new people into the workforce and what routes we use for that. But actually, Joe and I are 30 years in. There's something about how you educate the people who are already in the workforce, as well as obsessing about the people who haven't yet entered the workforce. We've got to find ways of doing both. I think we've also heard from the panel the importance of the fact that this conversation about workforce isn't a niche activity. It's not just the preserve of people like Joe and I from our professional backgrounds. It's vital to every part of the service. Integration is about relationships and understanding, as well as some of the kind of service models and technical things that we need to do. That the future is about a conversation about shape and size, shape as well as size, sorry. That there is something about action being rooted in data and insights, and there is something about action being rooted in some of the enablers that we now have access to, and we've heard examples of some of that. We still need a national plan. We still need the government to commit to having a national plan and to funding the delivery of that plan, but actually its implementation, making it real, we can start on that now. You're already doing lots of the things that we've touched on today, and actually delivering the plan will require all of us to be part of doing that. Thank you so much to the panel. If you could show your appreciation to Raj, Honor and Joe. Thank you also for the fantastic questions we've had, and for the quality of conversation you had with your neighbours. It sounded great. And I hope you enjoy the rest of ConfedExpo, and we look forward to seeing you over the course of the 2 days. Many thanks.